Hi, good morning to all the students, and sorry for a bit of a delay today. We had some connectivity issues at our center, but I hope now everything is resolved. And I got a lot of questions from all of our students yesterday, so which meant that lot of people are taking very keen interest as far as orthopedics is concerned, which is also for me an extremely good thing to know. Right. So let's now focus. We got slightly delayed today, but we will now start with the topic for today. As I told when we were closing yesterday, that we will start with complications of fractures. This is an important topic from the first the chapter and overall from the examination perspective, because a lot of questions are framed from this topic, which is complications of fractures, and every single topic has been asked in one or the other examination in some or the other form. Now, there are so many fractures and associated injuries which happen that invariably clinically there are chances of some kind of complications which can take place along with these injuries. So overall, in terms of either a single fracture or a polytrauma, the complications can actually be grouped into three different types. So there can be immediate complications, and these are the ones with which the patient present when they come to the hospital. So along with the fracture, these are the important complications which we need to focus upon. And what could be these immediate complications? Especially in fractures like pelvis and femur fractures, a lot of blood loss takes place along with the injury. So patients can end up with hypovolemic shock, or in some fractures, as we discussed yesterday, fracture humerus with wrist drop. Similarly, there are a lot of fractures and dislocations which can actually lead to either a nerve injury or a vascular injury or some other injury to the anatomical structure. So there can be injury to the blood vessels and the nerves. Then there could be some early complications, and early means, so immediate means that the patient comes to the hospital and presents with these complications along with the fracture. Early means that the patient comes to the hospital with trauma but develops these complications within the first 24 to 72 hours after the trauma. So what are these early complications? So the early complications, majorly there are 5 early complications. One, which is seen in patients with polytrauma. This can be acute respiratory distress syndrome or ARDS. And I will discuss about every complication in detail right now, just for the purpose of enumeration, so that when you are revising in the examination, it becomes easier for all of you to assimilate this information. ARDS or acute respiratory distress syndrome. Then in fractures of long bone, like femur fractures, diaphyseal fractures, where a lot of bone marrow escapes into the circulation, you can see fat embolism syndrome. Fine. Then because of prolonged immobilization as a result of recovery stage of polytrauma or after the surgery, when the patient is lying down, not walking too much, long-term bed rest or immobilization can lead to thrombosis in the lower limb veins, which is called as deep venous thrombosis or DVT. And if one of the small fragment detaches from this thrombus and embolizes, it can cause pulmonary embolism. Sometimes as a result of high velocity road traffic accidents or some special circumstances like earthquakes, mining accidents, buildings collapsing. So when there is a clinical condition in which the muscles, the large muscles of the lower limb especially, they get crushed, it releases a lot of myoglobin into the body, and this myoglobin, being a very big molecule, causes a lot of nephro or renal toxicity and leads to a condition which is called as crushed syndrome. And finally, something which I discussed yesterday, I briefly touched, today we'll go into detail, is that in virtually all high velocity trauma, you have or you can have a circumstance when the intracompartmental pressure, so pressure inside the closed anatomical compartment can increase, and this can be because of swelling, because of edema, because of external compressive forces of plaster, because of anything. But when this pressure increases to an extent that it starts causing compression of the blood vessels, compression of the nerves, it leads to a condition which is called as compartment syndrome. So these are the 5 important early complications, and by early, please lay stress on the time period, because there was a question in this examination, the one which has just gone by, which clearly mentioned that patient has had a surgical procedure and after 2 months or 3 months it developed. So time period is very important. What is the time period we are looking at? Early complications are the ones which are notorious to develop as an immediate and early, within 2 to 3 days, sequelae of or result of the injury. ARDS, result of polytrauma, chest going bad. Fat embolism syndrome, result of a lot of bone marrow going into the circulation. DVT, a result of immobilization, veins developing thrombosis. Crush syndrome, result of myoglobin which is released into the circulation. And compartment syndrome, immediate and early result of this compartment getting swollen and then causing pressure or compression of the blood vessels in the nerves. So just focus in your mind that when there is a clinical question, what is the exact time period of the development of the complication after the related event incident, which is the trauma or a polytrauma or any kind of surgical procedure. The third complications which can be grouped are which are called as late complications. Late complications, they develop weeks to months after the initial episode of injury. So weeks to months after the injury are late complications and can be grouped basically into, so what are the late complications? If I treat a patient of fracture, so I do a surgery or I do something, what can happen? Either this fracture, as we discussed yesterday, does not join, or sometimes it joins and joins in the wrong position. So what can happen? you can have a condition which can develop malunion, union in a wrong position, delayed union. Delayed union means it is joining, but joining very late, very slowly, because of multiple causes, or sometimes non-union, fractures not joining at all. Old patients, and somebody asked me yesterday, some comorbid conditions like diabetes, malnourishment, hypoproteinemia, chronic liver kidney diseases, subclinical infections, open fractures. These are the important conditions which leads to the fractures, either uniting or joining slowly or not joining at all. So these are the complications which all we have to see in the clinical practice. Sometimes the fractures join, but they join with malunion. So in lower limbs, it produces a discrepancy or difference in the length. Some patients say, sir, I feel that after the surgery, the length of one of my legs has become shorter than the other. So now I have difficulty in walking, isn't it? So shortening, limb length discrepancies, rotational deformities, all can take place. So you can have some kind of shortening. Intra-articular fractures, the fractures which are communicating with the joint, if not fixed and if the articular surface not reconstructed properly, can lead to a lot of stiffness, deformity, post-traumatic arthritis. Patient's fracture healed, but healed in the wrong position. So joint surface is not good. So when the patient causes movement of the joint, it causes pain to the patient. Then I briefly touch upon a topic which I will discuss in detail today, something which is seen in a few regions of our body, in which after the injury, the blood supply gets hampered in that area. And when the blood supply is hampered, it leads to the necrosis or the death of the bony tissue. This is called as avascular necrosis, and there are two named complications which will come up when we are doing individual fractures. So one which will come up in supracondylar fracture is myositis ossificans. And myositis ossificans is nothing but calcification of hematoma inside the muscle. So when after the trauma, you see that inside the muscle there is a calcified mass which is formed and which is visible on X-ray. This is myositis ossificans. So tremendous inflammatory response going in a wrong direction. And finally, we will touch one late complication when we are doing Colles fracture. That is what is called as a Sudex osteodystrophy, also called as reflex sympathetic dystrophy, or RSD. So Sudex osteodystrophy or reflex sympathetic dystrophy is a condition in which an injury leads to activation of your sympathetic nervous system on the injured extremity, and this leads to a lot of swelling, lot of pain, stiffness, decreased movement in that extremity, and significant amount of bone resorption. And these are all what are found in RSD or reflex sympathetic dystrophy. We will study about these also in detail when we are doing Colles fracture later today. So these are the complications, right from the immediate complications to a lot of early complications and potential late complications which can develop. Remember, immediate is what the patient presents to you when he comes to the hospital. Early is what the patients develop within the next 24 to 72 hours after the injury has taken place. And late complications normally happen weeks to months after the injury during the course of treatment, and uh, these can manifest sometimes even as late as about 1 year after the initial injury. So these are the things which we have to deal with, and to make sure that good clinical results are achieved. Okay, so all these complications we'll take it one by one. So starting with immediate complication, hypovolemic shock. So all of you are aware about the definition of shock. It is a state of hypoperfusion to the vital organs, isn't it? And this can be because of anything. As a result of injury, if lot of blood loss has taken place. So in orthopedics, there are two important injury patterns which are notorious. So what is that? In hypovolemic shock, important causes. In orthopedics, fractures of pelvis, which are known to cause approximately 1.5 to 2 liters of blood loss, and fractures of shaft of femur or diaphysis of femur, which are notorious to cause a blood loss in the range of 1 to 1.5 liters. And in a body where the normal blood volume is between 5 and 6 liters, this is a significant blood loss. So, a patient who has pelvis fractures or femur fractures, especially if you have a bilateral femur fracture, comes to the hospital not only with pain and deformity as a result of fracture, but when the patient is in hypovolemic shock, you will have hypotension, so which is decreased of blood pressure. The blood pressure falls down. There is increase of pulse rate, reflex tachycardia, and overall decrease in urine output. There is a decrease in urine output. So you will have a patient who will be either oliguric or anuric. And these are the clinical features: severe hypotension with a very feeble pulse, steady pulse, reflex tachycardia, low urine output should tell you that the patient has lost a lot of volume of blood and this patient is in hypovolemic shock. So as far as the initial treatment of hypovolemic shock goes, crystalloids like normal saline, ringer lactate are given. Crystalloids like normal saline or ringer lactate are given. The best replacement in hypovolemic shock is blood transfusion. But since it is not easy to arrange blood initially, it becomes difficult, and that is why in normal clinical practice we start with crystalloids. Colloids are contraindicated. They are contraindicated in the initial management. Colloids are contraindicated in initial management because they cause further depletion of the intravascular volume. And once you have given crystalloids and blood transfusion, just remember the best prognostic marker. The best prognostic marker that adequate resuscitation in terms of volume or replacement of volume has been done only happens when the patient develops adequate urine output which is more than 50 to 75 milliliters per hour. So that is the best prognostic marker or adequacy of the resuscitation has been completed as far as hypovolemia. So these are the important points which you take into consideration. Obviously, you will bandage, you will ligate any bleeder, and you will try to stop if there is any vascular injury, I might just cause bleeding, because pelvic fractures very commonly associated with in such kind of vascular injuries, and a lot of blood loss takes place. So apart from that, you can pack into other things, but these are the major points in our mind as far as the management of hypovolemic shock is concerned. Okay. Now the next important complication is adult or an acute respiratory distress. This is an early complication, normally develops in patients of polytrauma. What is polytrauma? It is more than two organ systems are involved simultaneously. So when more than two organ systems are involved simultaneously, polytrauma is a condition in which the human body is in a state of stress. When the body is in a state of stress, it tries to counteract. And how does it do? Simply by release of lots of inflammatory mediators. Lots of inflammatory mediators are released, or inflammatory markers are released. While these inflammatory markers, they help us to counteract the stress in ARDS, these are basically seen to cause damage of the small pulmonary vessels. So small vessels like capillaries and arterioles in the lungs get damaged, and what they do once they are damaged, the fluid which is present inside these vessels comes out. So the fluid comes out in the lung parenchyma. Now, when this happens, see what is the role of lungs in the body. When you inhale, the lungs expand. When you exhale, the lungs deflate. When you inhale, the lungs expand, air goes in. That air is used to oxygenate the blood. And then this blood carries the oxygen to the various parts of the body. Correct? That is how the human body works. Suppose instead of these open spaces in the lungs, there is fluid which is present inside. What is likely to happen? Somebody will inhale, but where will the air enter? Because the parenchyma is full of fluid. So even after forceful inhalation, air entry is not adequate, oxygenation of blood is not adequate, and there is a clinical picture of what? Hypoxemia. And since there is hypoxemia, the blood cannot carry sufficient oxygen to the vital organs of the body. This is exactly what is ARDS, or acute respiratory distress syndrome. Okay, so this is exactly. So when the fluid comes out in the lung parenchyma, this impairs this impairs lung expansion. When this impairs the expansion of the lungs, it leads to decrease in oxygenation of the blood. So this is what is called as hypoxemia. This is called as hypoxemia. So when you see the patient, so what will be the clinical features? When we see this patient, the patient will be gasping for air. So tachypnea. What is tachypnea? Increased respiratory rate. But even though the patient is tachypnic, there is decrease in partial pressure of hypoxemia, as I told you, less than 50%. So there is decrease in partial pressure of oxygen, which is measured on arterial blood gas analysis. When you take a X-ray chest, a picture which is presented in front of you, all of you can see. So if I zoom this picture, look at on the left side, which is normal X-ray, and look on the right side, the amount of infiltrates which are present in the lungs. And this is nothing but pulmonary edema or fluid which has come out, which is impairing the expansion of the lungs. This X-ray picture is what is called as diffuse pulmonary infiltrates. Diffuse pulmonary infiltrates, and more often than not, the treatment for the patients actually needs mechanical ventilation. Mechanical ventilation. So you have to oxygenate the lungs by ventilator. You have to make sure that the blood is oxygenated and is able to carry out the oxygen to the vital organs. Till that time, these infiltrates clear up, and once they are clear, slowly and steadily the patient can be weaned from the ventilator and then brought back to the normal condition. This is a difficult condition to treat, and since it almost invariably requires the ventilatory support, it carries a risk of a very high morbidity and mortality along with it. So that is something which we have to remember in acute respiratory distress syndrome. Okay, so this is the first early complication. The second early complication is what is called as a fat embolism syndrome. And fat embolism syndrome generally is seen in fractures of long bones, and the most common cause for fat embolism syndrome is fracture shaft of femur. It can happen in other long bone fractures like tibia also, but femur is the most common cause for fat embolism syndrome. So what happens here? When there is a long bone fracture, like femur fracture, a lot of bone marrow escapes into the circulation. So when there is a fracture, the bone marrow, which is nothing but fat globules, they escape into the circulation. So a lot of bone marrow, which is fat globules, it escapes into the circulation. Okay. When this bone marrow or fat goes into the circulation, there is formation of free fatty acids. There are formation of free fatty acids, and it is this part. So these free fatty acids, they are the ones which cause vasculitis. Or so there is a clinical triad of fat embolism syndrome. So vasculitis of the lungs causes respiratory symptoms. Okay? So vasculitis of lungs causes respiratory symptoms. Of the brain causes cerebral symptoms like confusion, disorientation, drowsiness. And as you can see in this clinical picture, vasculitis of the conjunctival blood vessels and the skin causes small petechial rashes. So small petechial rashes are seen in the conjunctiva and the skin. All of you can see here. See these red spots or dots which are seen. Can you see? The red spots or dots which are seen in the conjunctiva and the skin. So these are small petechial rashes. So this is how the patient with fat embolism syndrome normally presents to you. The clinical diagnosis. The clinical diagnosis is by a criteria. So there are major criteria and minor criteria, which is called as Gert's criteria. Will not go into detail, but there is a combination of major and minor. So one major and four minor will tell you the diagnosis of fat embolism syndrome. So Gert's criteria is used for clinical diagnosis. For these patients, if you take X-ray of the chest, as all of you can see here, it shows infiltrates or involvements of the lung only in that part where the flat globules has gone, not the entire lung. So there is a patchy involvement of the lungs, not a diffuse involvement. These are called as patchy pulmonary infiltrates. Patchy pulmonary infiltrates, also called as snowstorm appearance. Patchy pulmonary infiltrates called as snowstorm appearance. So diffuse pulmonary infiltrates are seen in ARDS. Patchy pulmonary infiltrates are seen in fat embolism syndrome. And the treatment for fat embolism syndrome, see, the more the time this fracture remains unstable, again the importance of using Thomas splint as early as possible in femur fractures. Once you splint the extremity, there is no movement of the fractured fragments, which also causes decrease in the release of this bone marrow. So what will the logic to control this development of fat embolism syndrome? Early fracture stabilization, isn't it? Early fracture stabilization. The more earlier you do, the better, because less instability, less release of bone marrow, less chances of development of fat embolism syndrome. Okay, that's number one. Second, give low molecular weight heparin. Low molecular weight heparin to keep the blood thin. Steroids both in ARDS and fat embolism syndrome, really they do not cause any alteration in the, I would say, the evolution of the pathology. It is just that it decreases the inflammation in the lungs. So decrease or prevents is the better word, prevents inflammation of the lungs or pneumonitis, and that is the main reason why steroids are used. And some of these patients, even of fat embolism syndrome, need a ventilatory support. They need a ventilatory support till the time these infiltrates, as far as the lungs are clear, and then the patient can the lungs become clear and the patients have good ventilation as far as the lung is concerned. Now, in fat embolism syndrome, so difference in ARDS and fat embolism, ARDS is only lung and a result of polytrauma. Fat embolism syndrome is a result of a long bone fracture and basically is involvement of brain, lungs, skin. Right? So three things. It's a triad. Chest X-ray shows diffuse involvement of the area of the lung, which is called as diffuse pulmonary infiltrates in ARDS. While X-ray of the chest in fat embolism syndrome, a patchy involvement of lungs, which is called as a snowstorm appearance of patchy pulmonary infiltrates. In fat embolism syndrome, these fat globules can even be found in sputum and urine. That is also one of the tests. So we take a urine sample of the patient and check it microscopically for the presence of fat globules, sometimes in fat embolism syndrome. So when a lot of fat globules are there, you can actually visualize them in the urine sample also, which will not be the case in case of ERT. So that will not be seen in acute respiratory distress syndrome. Okay, this is clear? All right. The next complication is what is called as deep vein thrombosis. All of you have read about Virchow's triad. Stasis leads to thrombosis. Hypercoagulability leads to thrombosis. Now, in orthopedic practice, you have a patient of polytrauma, multiple injuries, you do surgeries. The patient needs a lot of time before they can return back to their original limits. Yes? Or we do surgeries in some patients, say like joint replacement, spinal cord surgeries. These patients again take a lot of time to get mobilized and come out of it. So just remember, just a minute. Hi, students. Please give me a feedback. I think we are having some complaints from the students. Am I clearly audible to everybody, or is there any problem like echo problem, or are you able to understand this or not? Because I don't want to run this class in a scenario when the things or voice problems persist and it's not clear. So if there is a problem, you have my number. Please WhatsApp me so that we can understand and try to solve this issue before we take this class further. I think we are having some issues with some of the students saying that the echo in this room is very high and they are not able to hear us clearly when they are putting this work. I think we'll have to break this class right now. And so right now it is 11:30 and no, I can understand. A lot of students are actually, I think the students who are having problem is one who are using their earphones while they're trying to listen, which we can understand. So while we rectify, I think it is 11:30 right now. I will try to basically, so we will break this link, and while we try to rectify this problem, I will try to restart this class at 12:30. So class, orthopedic class will restart at 12:30 p.m. Okay, 12:30 p.m. So 11:30 is, I will try. I mean that we started at 12:30, and by that time, hopefully, all these audio problems should have got resolved, right? So I'll see you at 12:30. See you.